Now, these are the different types of angina or angina, and you can see the way it shows in the picture. So, the types of angina is seen in page 757, chart 27-2. It shows the different types. Like I said, let's start with a stable angina. It's a chest pain or discomfort that is associated with physical activity. Okay, so it is typically linked to it's a fixed plaque formation. So what kind of symptoms do they have? So this patient will have chest pain or any kind of pain and alleviated with rest or medications. And the medication that we give for angina is the drug of choice is nitrates or the nitroglycerin. These are potent vasodilator. They dilate the coronary arteries, thereby it improves the oxygen-rich blood flow to the heart and then prevents and stops the chest pain. Okay, those are stable angina. Next, we have the unstable angina. It refers to the chest pain that can occur at rest. Of the two types of angina, unstable angina is the most concerning, and it is identified as the initial phase of acute coronary syndrome and can be a precursor to myocardial infarction. It should be treated as an emergency, guys, because this unstable angina, it's usually prolonged and may not be relieved with medication. So, in addition to nitroglycerin, these patients may require medication such as morphine. Obviously, supplemental oxygen is probably necessary because of the demand of oxygen to the myocardial cells that's been damaged. So, both stable and unstable angina, they're both temporary and it can be reversible. Now, we also have the intractable or what we call refractory angina. It may mean severe incapacitating chest pain. Okay, a variation of an unstable angina is variant or Prince-Meadows angina. Okay, wherein there's a blockage of blood flow in the coronary artery that causes the coronary artery to have the spasm. Okay, and there is no black or I'm sorry, there is no plaque formation. However, the coronary seems to be spastic, um, but commonly after sclerotic change, it typically occurs at rest and in clusters. So interestingly, with Prince-Meadows angina, it normally occurs at night between midnight and 8 a.m. with chest pain at rest and reversible ST segment elevation.
Angina pectoris, or simply angina, refers to chest pain or discomfort caused by reduced blood flow to the heart in a condition known as myocardial ischemia. Angina is described as a squeezing pain or heaviness in the chest, which may also spread to the neck, arms, shoulders, and back, or in the stomach area, particularly after meals. Women are more likely to experience a burning sensation or tenderness instead of squeezing pain. Angina is not the same as heart attack. It is associated with transient ischemia of the heart without permanent damage, while heart attack is when a patch of the heart muscle dies from lack of oxygen. But having angina significantly increases the risks for heart attacks, especially when left untreated. Angina is most commonly caused by the narrowing of one or more coronary arteries that supply the heart. This can result from a fixed obstruction by cholesterol plaques or a temporary constriction due to blood vessel spasms. Angina can also be caused by anemia when the flow is adequate but the blood does not have enough red blood cells to carry oxygen. There are several types of angina. Stable angina, the most common form, is usually caused by a fixed obstruction, a plaque. Stable angina is predictable, with familiar pain patterns and typically prompted by physical exertion, when the heart requires more oxygen than it can get from narrowed vessels. Factors that constrict blood vessels or increase blood pressure, such as emotional stress, cold temperatures, or heavy meals, may also induce angina. Stable angina does not happen at rest when the reduced flow is sufficient for the low demand of the heart. It usually subsides when the inducer is removed and responds well to medications. Unstable angina, on the other hand, may occur unexpectedly, even at rest, with a changed pattern from the usual stable angina. It is more severe, lasts longer, does not respond to rest or medications, and is often the sign that a plaque has ruptured or a clot has formed. Unstable angina is a medical emergency as it often precedes a heart attack. Electrocardiograms of patients with obstructive angina commonly show ST segment depression during attacks. Diagnosis is confirmed with stress tests, where patients are monitored while exercising. The site of obstruction can be detected with imaging techniques such as angiography. It appears, however, that a significant number of patients with stable angina symptoms have more or less normal coronary arteries on angiograms. These cases are now recognized as microvascular angina, where the problem lies not in the large coronary arteries, but their tiny branches, and is therefore undetectable by angiography. Microvascular angina is much more common in women than in men. Variant angina, a less common type, is caused by vascular spasms of coronary arteries. Variant angina can occur during rest, usually at certain times of the day, often at night. Emotional stress, smoking, and use of cocaine are known triggers. Variant angina is often severe, but responds well to medications. Diagnosis is by presence of ST segment elevation during attacks and provocative testing with drugs that induce coronary artery spasms. Treatment of angina aims to relieve symptoms, reduce frequency of future anginas, but most importantly, reduce risks of heart attacks. Apart from lifestyle changes to modify risk factors, treatment options include a number of medications and surgical procedures. Nitroglycerin, a potent vasodilator, is most effective for acute anginal attacks. Long lasting nitrates, antiplatelet drugs, beta blockers, and calcium channel blockers can be prescribed to prevent future anginas. Several revascularization procedures are available to restore normal blood supply to the heart. Coronary angioplasty makes use of a balloon and sometimes a stent to widen the affected artery. Coronary bypass uses a graft to create an alternative route for blood to flow beyond the site of blockage.
History and presentation of pain are significant in evaluating patients with angina. So I have come up here the PQSTA of chest pain. Okay, remember this mnemonics as this is assessment for pain perception. And it's also a way of assessing chest pain, especially for cardiac patients. I added an A in here, which means associated signs and symptoms. This method is especially helpful when you approach a new pain problem. And the good thing is that this method can also be used to assess any kind of symptom, not only with pain. Um, so, say patient came in for chest pain, you're not just gonna ask what's the pain like or numerical verbal rating scale of pain, but you need to ask further, dig into more questions, right? So for your assessment with a P, ask the following questions: what precipitated the pain? Were you eating? Were you driving? Were you resting? Did you wake up this way? Okay. Were you mowing the lawn? Were you having a large meal? Those stuff. Or has anything palliated the pain? Or what was the pattern of the pain? All right. So that those are your P's. The Q's, what are the quality and quantity of the pain? So ask all. Just let the patient describe how they feel. So is it sharp? Is it a stabbing pain, aching, burning, stinging, deep, crashing, vice-like, knife-like, gnawing, pressure, tightening, aching, indigestion, excruciating? Or some patients say it actually went to my flex question way back. Elephant stepping on your chest kind of pain. So ask how they actually feel. They can describe it for you. R, radiation or relief. What is the region of the pain? Does the pain radiate to just to other areas of the body, or is it just local? Local just on the chest. Or does it go all over to your jaw, to your neck, to your just left arm or right arm, to the back, precordial arms? So or frank or back pain. So wherever you can ask if they radiate, and does anything relieve or reduce the pain? So you have given nitro, you've given her oxygen, you gave some morphine, you put the patient on bed rest. After that, nothing changed. So you want to know, or if the patient says, I did everything, nothing helped me, I'm still getting my chest pain. So those are your R's. S, severity, your most favorite one. Can asking for the severity or intensity of the pain. So you're going to be asking your patient on a scale of 0, not 1, 0 to 10, 10 being the highest or 10 being the worst, and 0, no pain at all. How's your pain level at? Okay. T is the time and treatment. So what is the timing of the pain? When does it begin, or when did it begin? What time? How long did it last? Or how is it related to other events in the patient's life? Was it sudden? Ask the patient about the duration. Was it 2 minutes, 3 to 5 minutes? Is it less than 20 minutes? Okay. Was it increasing in frequency? Those are episodes that you need to ask. All right. And treatment, like the relief, ask for, did nitro help you, did oxygen help you? When you stop eating, did you try to sit down? Or when you stop mowing the lawn, did you try to rest, and did it help you? So those are things that you want to know about T. Lastly, I put an A in here because some patients will have chest pain and will have other kinds of signs and symptoms such as fatigue, they felt dizzy, they got short of breath or dyspneic, they got the aphoretic, nausea and vomiting and all that stuff. Okay, so to add more to this, chart 27-4 in page 760 is a way to gather information about the symptoms and activities, especially those that precede and precipitate attacks. So again, guys, PQRSTA of chest pain. Do not forget that. Now, the objectives of the medical management of angina are to decrease the oxygen demand of the myocardium and to increase the oxygen supply. Medically, these objectives are met through pharmacologic treatment or therapy, and they want to control risk factors. Alternatively, reperfusion procedures may be used to restore the blood supply to the myocardium, and these are called, or this includes your PCIs or percutaneous coronary intervention, and examples of the procedures are your PTCA or percutaneous transluminal coronary angioplasty or PTCA, or also your stents or simply in or intracoronary stents are called just cardiac stents. Also surgical procedures such as your CABG. We will learn more about that as we go on to the next slides. So what are the medications we give? First and foremost, we want to give our nitrates, which is your nitroglycerin. This is the standard treatment for angina pectoris. And like I kept on saying, it's a potent vasodilator that will improve the blood flow to the heart muscle and will relieve the pain, and it will dilate your coronary arteries. And the also it dilate the veins, causing venous pooling of blood throughout the body. So as a result of that, there will be less blood return to the heart, and the feeling pressure or your preload is reduced. Okay. Your nitrates relaxes the systemic um arterial blood vessel, lowering your blood pressure and decreasing your afterload. So, but the thing here with nitroglycerin is you be careful when giving this medication, because if the patient is hypovolemic, meaning there's no adequate circulating blood volume, the decrease in filling pressure can cause a significant decrease in cardiac output and blood pressure. So with nitro, you can give it through several routes. You can give it the spray, you can give it through sublingual tablets, oral capsules, topical agents, and intravenously. Okay. So page 759 shows you the summary of medications used to treat angina, and chart 27-3 will give you self-administration of nitroglycerin checklist. So you guys may want to read that out as well. Next medication is your beta blocker, okay? So your beta adrenergic blocking agents or your OLOLs, OLOL, such as metoprolol, atenolol, those are their guys. So what it does is it inhibits your sympathetic nervous system response to physical inactivity or physical activity, should I say, thereby decreasing your cardiac workload and oxygen consumption. All right. Not going to go through that. If you need to remember most of it, go back to the hypertension lecture. Next, a recap about your calcium channel blockers. These are these are a very nice drug. Remember, verapamil, nifedipine, and amlodipine. So what they do is they dilate the coronary arteries and come out with lower blood pressure and increasing blood flow through the coronary arteries and decreasing the workload on oxygen consumption and increasing the blood supply to the myocardium. Next, antiplatelet and anticoagulation medications are also important. Give me an example of your antiplatelets. These are your aspirin. We do have the P2Y12 or adenosine diphosphate receptor antagonist. The most common example of this is your Plavix or clopidogrel. These are antiplatelet medications and they're given to prevent platelet aggregation and subsequent thrombosis, which impedes blood flow through the coronary arteries. Your anticoagulant, which is your most common heparin, okay, or Lovenox, which are your low molecular weight heparin. Um, Obviously, it's an anticoagulant. You prevent the formation of new blood clots, and they're given to your patients with angina as well. We also have the eptifibatide or integralin. These are your glycoprotein 2B3A agents, and these are indicated for hospitalized patients with unstable angina as an adjunct therapy for percutaneous coronary interventions. Lastly, you want to give your oxygen, and this is usually initiated at the onset of chest pain in an attempt to increase the amount of oxygen delivered to the myocardium and to decrease pain. So these are actually the most important medications that you need to give when the patient has angina or CAD. So what are the medications we give? First and foremost, we want to give our nitrates, which is your nitroglycerin. This is the standard treatment for angina pectoris, and like I kept on saying, it's a potent vasodilator that will improve the blood flow to the heart muscle and will relieve the pain, and it will dilate your coronary arteries, and that also it dilate the veins causing venous pooling of blood throughout the body. So as a result of that blood, there will be less blood return to the heart, and the feeling pressure or your preload is reduced. Okay. Your nitrates relaxes the systemic um arterial blood vessel, lowering your blood pressure and decreasing your afterload. So, but the thing here with nitroglycerin is you be careful when giving this medication because if the patient is hypovolemic, meaning there's no adequate circulating blood volume, the decrease in filling pressure can cause a significant decrease in cardiac output and blood pressure. So with nitro, you can give it through several routes. You can give it the spray, you can give it through sublingual tablets, oral capsules, topical agents, and intravenously. Okay. So page 759 shows you the summary of medications used to treat angina, and 27-3 will give you self-administration of nitroglycerin checklist. So you guys may want to read that out as well. Next medication is your beta blocker, okay? So your beta adrenergic blocking agents or your OLOLs, OLOL, such as metoprolol, atenolol, Those are their guys. So what it does is it inhibits your sympathetic nervous system response to physical inactivity or physical activity, should I say, thereby decreasing your cardiac workload and oxygen consumption. All right. Not gonna go through that. If you need to remember most of it, go back to the hypertension lecture. Next, a recap about your calcium channel blockers. These are ca- these are a very nice drug. Remember, verapamil, nifedipine, and amlodipine. So what they do is they dilate the coronary arteries and come out with lower blood pressure and increasing blood flow through the coronary arteries and decreasing the workload on oxygen consumption and increasing the blood supply to the myocardium. Next, antiplatelet and anticoagulation medications are also important. Give me an example of your antiplatelets. These are your aspirin. We do have the P2Y12 or adenosine diphosphate receptor antagonist. The most common example of this is your Plavix or clopidogrel. Clopidogrel. These are antiplatelet medications and they're given to prevent platelet aggregation and subsequent thrombosis, which impedes blood flow through the coronary arteries. Your anticoagulants, which are your most common heparin, okay, or Lovenox, which are your low molecular weight heparin. Um, Obviously, it's an anticoagulant. You prevent the formation of new blood clots, and they're given to your patients with angina as well. We also have the eptifibatide or integralin. These are your glycoprotein 2B3A agents, and these are indicated for hospitalized patients with unstable angina as an adjunct therapy for percutaneous coronary interventions. Lastly, you want to give your oxygen, and this is usually initiated at the onset of chest pain, in an attempt to increase the amount of oxygen delivered to the myocardium and to decrease pain. So these are some, or these are actually the most important medications that you need to give when the patient has angina or CAD. So, with our nursing process, what would be our nursing interventions? Okay, we've given you the medications. Prior slides, I have shown you the diagnosis, collaborative problems, or complications, and what are your goals. So, our goal actually is to treat your angina. So, excuse me, our priority is to stop all activity once the patient is complaining of chest pain. We want to make sure the patient sit or rest in bed, preferably in a semi-fowler position. Okay, you want to assess the patient while performing other necessary interventions, such as obviously your vital signs, observe your respiratory distress, you assess for pain, and for most obvious reason, you want to do your EKG. Um, Administer all the meds that I mentioned as ordered or by protocol. Every institution is different. You want to reassess for pain and you want to administer nitroglycerin. If you read your chart, the chart about administering, you want to give it up to only 3 doses, 5 minutes apart. Um, and if it doesn't work, you can give your morphine, kind of thing. Next, oxygen, 2 liters by nasal cannula. These patients, when they have chest pain, they think they're gonna die. So you want to make sure you reduce your anxiety. Okay, calm manner. Don't aggravate your patients. Don't tell them they're overreacting because maybe it does really hurt them. So don't be the stressor. So make sure you do stress reducing techniques. Patient teaching, okay? You want to address your patient's spiritual needs as well, okay? If they need rosary before, beside them, let them do it, okay? You also address not just the patient, but also the family's needs as well. Angina pectoris is chest pain. So you want to prevent pain and you want to treat the pain. So you may probably end with ask for some pain medication. But basically, once you give your vasodilators, your nitro and your morphine, which is also an opioid, then that will probably relax your patient and decrease the amount of pain that the patient has. Obviously, if the patient's still in the hospital, you want to identify the level of activity that could cause patients prodromal sign and symptom. So therefore, you want to alternate activities with rest periods. Things that I want to like share here, especially if the patient needs blood collection in the morning. So the phlebotomist come in at 4 in the morning. Just wait until then. You can disturb the patient and do your set of vital signs if the patient's stable, that kind of thing. So you don't have to bother them and wake them up because they need this rest period. Okay. So you want to educate your patients about self-care. Again, I kept on mentioning balance activity with rest. Um, you want to make sure when the patient is going home to avoid exercising in extreme temperatures. Tell them to avoid over-the-counter medications that may increase heart rate or blood pressure. Okay, again, not limit but stop using tobacco products, and explain the diet, which is low fat and high in fiber diet. Okay, now we'll proceed with acute coronary syndrome and myocardial infarction. ACS, or acute coronary syndrome, is an emergent situation, guys, and it's characterized by an acute onset of myocardial ischemia that results in myocardial death, which is a myocardial infarction, if definitive interventions do not occur promptly. So, although the terms coronary occlusion, heart attack, and myocardial infarction synonymously, or they are used synonymously, the preferred term here is myocardial infarction. So, the spectrum of acute coronary syndrome includes your unstable angina, your ST elevation MI, and your non ST elevation MI. So if you remember from the previous slides that, an abrupt interruption of oxygen to the heart muscle or myocardium produces myocardial ischemia, okay? As a recap, this ischemia can lead to tissue necrosis or infection if blood supply, necrosis and infection, not infection, sorry, if blood supply, um, and oxygen are not restored. So again, think ischemia reversible. An infarction results in permanent damage. And when you say permanent damage, it will be irreversible. So when the cardiac muscle suffers ischemic injury, you want to make sure you fix that. The way to check is looking for cardiac enzymes that are released into the bloodstream, providing specific markers for your MI. So going back, when the blood flow to the heart is compromised, ischemia can cause chest pain as well. Anginal pain is often described as a tight, squeezing, heavy pressure, constricting feeling in the chest, and you know that. I explained that. They are relieved by rest, nitroglycerin, and oxygen, and that differentiates MI from angina. I'll tell you more about this on the next slides. So the difference with angina and MI is that angina is, or angina pectoris, is a warning sign of impending acute myocardial infarction. Okay, the area of infarction in clients experiencing a myocardial infarction or MI develops over minutes to hours. So that is why we call this time is muscle. So, as the cells are deprived of oxygen, ischemia develops, and then cellular injury occurs, and then the lack of oxygen results in infarction or the death of the cells. So, the expression time is muscle reflects the urgency of appropriate treatment to improve patient outcomes. And approximately every 43 seconds in America will have an MI, or 43 seconds in of Americans will have an MI, and many of these people will die as a result. I know I keep on saying the word die for the past 2 or 3 slides. I mean, three cardiac material. However, you want to make sure to recognize this early and treat these patients presenting with MI so they will improve their chance of survival, okay? And as we all know, well, now I'm saying it, research shows that improving outcome following a myocardial infarction in clients or clients with myocardial infarction are treated with aspirin, beta blockers, your ACE, or angiotensin converting enzymes, and ARBs, or your angiotensin receptor blockers. So chest pain that occurs suddenly and continuous despite rest and medication is a presenting symptom in most patients with ACS. Some of these patients have prodromal symptoms or a previous diagnosis of coronary artery disease, but others report no previous symptoms. Okay, so patients may present with a combination of symptoms, including chest pain and short of breath, indigestion, nausea, anxiety, cool, pale skin, moist skin. They can be tachypnic, tachycardic. Um, and these are symptoms caused by stimulation of their sympathetic nervous system. They may be present for only a short time or may persist in many cases, that will show symptoms of MI and cannot be distinguished from those of unstable angina, hence the evolution of the term acute coronary syndrome. Now, the diagnosis of ACS is generally based on the presenting symptoms, the 12-lead EKG, and the lab tests, such as your serial cardiac markers, are performed to clarify whether the patient has unstable angina or ST elevation MI. The prognosis depends on the severity of coronary artery obstruction in the presence and the extent of myocardial damage. Physical examination is always conducted, but the examination alone does not confirm the diagnosis. So the patient history also should be included. This patient should be able to describe the presenting symptom, any history of previous cardiac or other illnesses, and the family history of heart disease. Uh, they should also give you information about their risk factors. Okay. And lastly, the ECG, the 12-lead ECG provides information that assists in ruling out or over time the location, the evolution, and the resolution of an MI, so we know what to identify and what to monitor. Okay. Another diagnostic procedure is your echocardiogram. It is used to evaluate ventricular function and may be used as diagnosing an MI as well, especially if the ECG is non-diagnostic. As I mentioned earlier, lab tests such as cardiac enzymes and biomarkers, which include troponin, creatine kinase or your CKs, myoglobin, and your troponins. Okay, remember that these enzymes are released when the heart sustains an acute injury.